Okay, we're going to go ahead and get started with the final session, I believe. For those of you that don't know me, I'm Kevin Atkins, Engagement Manager for HealthPOINT. And I've been involved in a project with the South Dakota Department of Health called Million Hearts. So when we were putting this together, I reached out to a couple of rock stars of ours on the Million Hearts side, and it's my pleasure to introduce you to these rock stars. Melissa and Heather, they are basically the data and quality people for Avera Parkston Clinic, St. Benedict, right? So they're going to give you a success story, they really are rock stars. So looking forward to it.
Thanks for having us here today. And like Kevin said, my name's Melissa. I'm Heather, and we in rural health wear a lot of different hats. So me and Heather both do clinic quality, and then we have several other things we do. I'm actually a behavioral health clinician, and I do grant finance too, so I have an entourage of different things.
And I work in health information, doing analysis of charts and transcription and clinic quality with Melissa.
We cover a lot of areas. So when we first started working with the Department of Health and Kevin and Holly and everyone else that's helped us with this Million Hearts, one of the most important things that we learned is how to look at our data differently. And I know you guys have been talking about that all day, but it really started to hit home with us with this project because we had done some other quality projects or had been in the middle of them. And we were doing pretty well, we thought, but we really weren't optimizing our data and learning from it. So we think we've done better with that over the last year. So we've been working on this Million Hearts project since May 1st, 2015. So just over a year.
We, with this project, have learned how to look at our data, how to use our data better. Nobody understands it. We've gained lots of knowledge with that, and nobody likes to change processes. We learned that we have to change processes after we look at our data.
I think one of the things that's kind of funny is I like to change things because I'm a pretty competitive person and I like things to be done well, and not everyone is like that. So sometimes being really excited about it and, oh, this is going to be so much better if we just do a few little things, not everyone else is as excited, and especially if they don't understand why or understand how the numbers can connect to processes. So that's something that we've really learned over time and that we feel like everyone in our clinic and hospital is starting to embrace. So when we first initially got started on the data, we had to look at primarily cardiovascular measures because we were doing Million Hearts. So the aspirin, the ABCs. Are you guys familiar with the Million Hearts initiative? Okay, so the Million Hearts initiative, maybe I should back up, is to prevent heart attacks, basically, in the U.S. So it's a federal initiative, and it's the ABCs of Million Hearts is for aspirin, blood pressure control, cholesterol management, and smoking cessation. So when I'm talking about some of these measures, we obviously do look at other measures too throughout monitoring QRS and ACO measures and different things we do, but for this presentation, we'll talk about those. So those kind of cardiovascular measures. So like what we just heard a little bit ago, when we first started looking at the data, we knew it wasn't good data. We couldn't say why though, necessarily. So until we started to get good at looking at our data and knowing what was wrong with it and what was right with it, we didn't share it with the providers, and we didn't really share it with the clinic staff because for the reason that we don't want to be told, oh, this data's crap, it's no good, I know this is wrong. So we worked really hard at the beginning to try to get good data integrity.
Workflow. It was huge. We had Kevin and his team come in and evaluate the process that we were currently doing and what our future process was going to be. We did that with our front office staff and with our nursing staff.
When we looked at those, for the nursing staff, we evaluated their workflow from when they went and got the person out of the front desk, when they were ready to be seen, through to when they roomed them, got their vitals, got templates pulled up, until they're basically doctor ready. So obviously in a family practice clinic, people are coming in for lots of different things. So the workflow wasn't going to be exactly the same for everyone, but we wanted to see what areas we could make exactly the same no matter what patients were coming in for. And we did the same thing with the office staff at the front. It was very amazing how many times we've had people in the clinic 10 times in the past year and their insurance is still wrong. There's not an updated phone number. So we went through all those processes to try to standardize that because it really started at the front end. So this is what our workflow assessment looks like. So Heather's going to hit a few of the high spots with the checking in of the patient. We know you can't see it very well, but we want to just give you an idea of what one looks like as we went through it.
One of the things we learned most with our front staff was that everybody did it different. Nobody did it the exact same order, the exact same way every time. We standardized that with our process with this workflow. We now have them all doing the insurance first or scanning in their license. The one big thing we noticed is that some people, when you had a new patient, they would hand that paperwork to them, go sit the patient down, have them bring the information back, and then check the patient in. Other ones were checking the patient in, having the patient do the paperwork. At that point, when they were checked in, they were realizing the nurse thought they were ready to be seen. They weren't. That was backing up our process. Backing up to that time, therefore we were off track. Our times were ready. We were behind before we even got started in the morning.
Those are a couple of the high spots with that. And then here's the one for the nursing when we were rooming them. And we tried to go through and, like I said, kind of made different adjustments where needed, but people weren't weighing people the same. Some people had shoes on, some people had shoes off. Some people didn't have height. Some people said, here's your height. This is what it was last time. Just putting the same thing in, which is a big problem with kids, right? I mean, not as much with adults, but kids grow. So we wanted to make sure all that stuff was done accurately. So making sure people had their shoes off. If the patient was pregnant, making sure that they were getting in for their cares, you know, so just addressing more things as the person was getting groomed. So we also use this as an opportunity to use the same template every time. So when the nurses were coming in, maybe one doc liked one template, one doc liked another, one doesn't use them at all, he just dictates everything. So we really use this to try to springboard into, here's the template we're going to use, this is why we're going to use it, and we're going to give it a try. So we actually told them Kevin's idea, so they would maybe be a little bit more receptive, and they were actually. So then as we did this, when we rolled it out to them, we started using the continuous PDSA cycles throughout everything. So when we were doing the workflow assessment, okay, we're going to try it this way. I know some of you guys don't like it. That's okay. Let's just, everyone agreed to give it a fair shot. Front desk nurses, everyone agreed to give it a fair shot for 3 weeks. And then I said, okay, we'll come back together at our next staff meeting, and then you guys say what worked well and what didn't. They started to be more open. They started to communicate better. Certain processes that no one had really realized were a problem before. But really started communication, and after really seeing demonstrations said, okay, we'll change that then. It's not that big a deal. Or you need a second monitor out at the front. So you have 2 monitors when you're checking people in, so you don't hang out of the other. A second monitor. So we made a bunch of changes, and our administration was in on those too. So basically, no one was really told no on anything initially to be able to get some more buy-in from staff that if they feel like that there is a change needed, that they can actually voice that, and it can be tried. Maybe we'll change back, maybe we'll do something different.
Gaining confidence in the data, huge, huge, huge. We took the data we got, compared it to many dashboards that Melissa Melissa has access to. And we drilled down specifically down to the patient, made sure everything was where it was supposed to be, found lots of errors, contacted lots of people. Our data is way better now than we were a year ago.
I think the one big thing with the data, and Heather is, no one can drill down data like Heather can. She's really, really great at it. So we could look at it and say, and we had a diabetic project on, so I knew the diabetic patients. I'd been in team medical visits with them, so if they were a patient population I knew that we had 305 diabetic patients. I knew that 60% of them didn't have an A1C out of control. I just knew that from doing their A1Cs, from looking at their labs, from working with them. So when we're getting that kind of data back, we started to be able to get a pretty good idea of, I could pick this out, I know this is wrong, this is where we start drilling down, or I have no idea about this area, so let's not address this right now, let's get some of these other ones that we know through either knowing the patients, cross-referencing data. So we at least had a starting point, because if we're looking at all the measures and going, I don't know which ones are right, I don't know which ones are wrong, I don't know if this is realistic, so we started with the one area that we knew the data was wrong, and then literally just started drilling down every week. And then when we contacted our people that do the report for us, we didn't just say the numbers are wrong, we said, here's an example of the numbers that are wrong and why they're wrong. So then they had a little bit better idea of how to go in and fix some things and look and see how the IT structure could be improved. So that's a daunting process, and that's an ongoing process. So we continue to do that all the time. But we actually feel more confident in the data, and if we don't, we just know, we just start doing it out of it.
Now that we're confident in our data, we are sharing that with our nursing staff, our providers. We hang it in. We also have set up a quality team within our facility that Melissa and I both are on, and that helps also. I think just the providers themselves understanding the data, how we're getting the numbers, where their numbers are coming from, and what they need to do within their documentation to hit those points.
A lot of it, I think one really good example, and this was a meaningful use number, we have one physician that says, see, this data is no good because I look at every one of my patient's meds on the med rec and I don't have 100%. I said, oh, okay, well, do you ever click the button that says you looked at it on your med rec? I don't even know what you're talking about. I don't even know it's there. Well, here, let me show you. Okay. You bet like 100%. He hasn't missed a click like in 6 months, you know? So sometimes it's those little things. I know where it is.
You give them a dog biscuit.
I know. So sometimes it's those simple things that maybe they don't even know what the data is. Sometimes providers will come in either one of our offices and say, we don't understand why our numbers are low, because the stuff is available. I mean, it's in the clinic, it's emailed out to everyone, and really for healthy internal competition, because providers are all high achievers, right? We're all kind of internally competitive. So it's not that they're necessarily competitive with one another, but they want to see their numbers do better over time as well. So we make sure that they have all that available to them and that they're getting it. And if they don't understand where the data is coming from or what's going on, then we can sit in the this month, but they were good last month. Did you do anything different? Did you work with a different nurse? Maybe the nurse actually need a little bit of training or whatever it is. So being able to at least discuss it over time when they can see trends. And then one big thing was everyone wants to get credit for things you're doing, right? Just like our one doc that he looks at the medications every time. I truly believe he did. He's a great doc. Well, to pull it out of an EMR, sometimes they don't understand it one of the parts, like you were showing, until you tell the record to do it.
These were the dashboards and patient registries that we use that were available. As Melissa stated, she started with diabetic, and that was another project. She had that drill down. We now are able to see our preventative health, well child, discharge follow-up, and our new one is our hypertension. This helped us drill down in our PQRS because we knew where the numbers were different and how to manage those numbers a little better.
So like if our diabetic registry says that of my 305 patients, 75% of them have had their cholesterol done and are with a goal, and then our PQRS says it's 25%. Pretty easy to cross-reference it when we've got those data points. So that's what we're kind of talking about when we use the registry, and then started using these when we start getting patients in for follow-up, calling patients, sending blood pressure monitors home with them maybe, just in whatever way we can use them. And every month the provider gets their own list, so they get their entire list of, here's all your diabetic patients, this is where they're at right now, here's all your colons, paps, mammals, flu shots, so they get that, so they don't have to go in and start calling people, but all that maybe magical thinking of, well, we do this, we get all these patients in. We just really had no idea how much stuff we missed until we had something showing us. I mean, we truly did believe that we were doing a really good job, and we were doing a good job when we got people in, but it's amazing how many things were missed inadvertently just because we had no way of having data to show that.
Scanned documents. Our providers did not like the scan documents. I don't like the way it's labeled. I don't like anything about it. So we sat down with the gal that scanned, there's one in our facility, and talked with her and got her. If she saw a app, for example, that was not from our provider within our system, she would go in and manually enter that. She does that with that retinopathy exam. And CPAP compliances, it has changed the way docs look at things. They can actually see it in one nice snapshot. So without digging through a scanned document that may not be labeled diabetic retinopathy, but other reports, or just no name attached to it. So they know exactly where to look and find it.
The other thing for quality too, the docs would say, well, we know they've had their mammo done or their PAP or whatever because I've got the report here. Well, you can't pull data from a report that's text, right? We all know that, but it takes a lot of manual labor to read every report, look, here's your mammo date, take it from here, put it in your health maintenance in your chart, and then scan it in. So it took a lot of hours. We probably entered over 1,000 PAPs, mammals, and colons. It does take a lot of time to do that, and we have been very conscious of what we scan. We can only control what we can control. We control what other facilities scan in, but we can definitely do scanning. So that's another kind of PDSA that we work on throughout this process. So this is just an example of what happened when we got the numbers in here. So it wasn't our patients weren't getting screened for breast cancer, and I just use this one because it's the coolest. So back in August 2015, our baseline was at 57%. And then it started to come up a little bit when then we started kind of cross-referencing the data and seeing that we actually had one person for 8 hours a day start calling all these people and asking, have you had mammo? Are you due from it? Because it was such bad data. So when we started manually correcting the data, that's what happened in that time from about October to December. Now we're at 1.95 of our women and the patients have had their program. So huge difference, right? It makes a big difference if you're 91% versus 57%.
Reteaching. We teach and meet with our docs. Not quite as frequently as we used to meet with them every week on a Tuesday morning. And we educate on documentation, on the usage of the EMR, where to find things, input things. And we just continue to do that every day. We do it in meetings. We do daily lineup every day. in our facility, individuals talk to the providers, we talk to the nurses. Communication never quits.
So we feel like we're kind of at a place right now where we have at least a quality infrastructure started. You know, we've all got a long way to go, just quality infrastructure and a changing payment system. But with our, what we call our quality meetings, so once a month we meet, and Heather, myself, our CFO, our business manager for the clinic business, all there every time. So every month, the 5 of us are there. Then we have a team rotation. So one person, one of the whatever PCP, and then his or her nurses. So that everyone has a voice, everyone rotates through. We have to go 12 times a year. They only feel like, geez, I only have to go once a year. It's not that big of a deal. So the teams are rotated through. And then at the end of those, well, obviously we discuss ongoing projects, quality data, dashboards, new areas to address. And we end with a monthly quality goal. So they can pick it. It can be whatever. So this may sound kind of silly, but one of our docs 2 months ago said, I hate the big biohazard trash cans in the clinic rooms. They're huge. They're like this wide, square. They're this tall. They have the red bags. And she's like, they're in the way. Kids are in the room. They're touching them. You know, only blood products can go in there. There's not much in a clinic that really goes in them, right? So she said, I think we should get smaller ones, get them out of there. Then we talked to housekeeping. Well, you know, we have to pay to get those kind of bags thrown away. There's dirty diapers in them. There is all kinds of things that aren't blood products. So really, it ended up being kind of a PDSA cycle in itself. It's not quality, like clinic quality, but we can measurably see how much money we save by getting a trash can this big with a little red bag and put it behind the exam table where kids can't mess with it. It's less of an infectious disease problem. So the quality goal, we're pretty much going to spin anything to a quality goal. If it's something that someone wants to address, and that's a valid thing, you know, over time, is going to save money with waste removal costs.
Specific to the Million Hearts Project, our goal for all our initiatives under the Million Hearts was 70%. We set our practice goal a little higher than 70%. Cholesterol management, we didn't have a good number there for a practice goal, as we don't have anything really to measure against that at this point with the reports we can get from the facility. So we don't have one in there.
So when we started off on some of those measures, like we said, the Million Hearts goal is 70% on all of those, but we wanted ours to be a little bit higher. And some of that, it was appropriate. We were already higher than 70%, so we wanted to use a little bit of stretch goals with some of those. But our blood pressure control was the lowest by far, so we wanted to address that one. The rest of them were relatively easy, you know, your aspirin use, to make sure that's updated in a med list, some of that stuff. But the blood pressure one has been an ongoing problem. So the first thing we did was started making sure that we captured all the blood pressures. So no charge blood pressure readings. So if someone came in from the street and said, my doc said a week ago he wants me to come in and just get it rechecked. So a nurse would recheck it and then say, oh, it's good. It's, you know, 120/80. Okay, thank you. And then they would go upon their way. She would probably tell the doc the blood pressure was good, but it didn't always get captured. We wanted to make sure that all of those got put in and captured. The other thing was adding a second set of vitals in the workflow. So when someone came in and they had a high blood pressure, mandatory, you have to do a second one. Well, a lot of times they were doing a second one, but they weren't putting that in, or they didn't know how, because you have to hit the second set button and then do some other things. Another documentation issue, we really pushed the use of templating for hypertension follow-ups. So it was all there and easy to see and easy to put in.
Manual versus auto, our machines. We had a concern that our auto machines were running high. We had a nurse over 2 weeks do a side-by-side. Every time she took it, she did a manual with it. We proved our autos were high. Some of those were 50 points higher. 30 to 50. Yeah. They were high. So we checked to see if we could have our machine, or they needed to be calibrated, and getting the nurses the tools they needed. We had some manual wall cups in our room that they had reported a long time ago that were broke. Nobody removed them. They left them there. We ordered manual cups in cups of all sizes. That was a complaint we heard from the nurses when we talked with them. We don't always have the right cup in the right room. Can't use that anymore. They've all got the same thing. And we centralized our supplies for our patient home monitoring.
So basically, we really what are the things that first, before we even try changing any of the docs workflow, or they try using our patterns, trying to whatever, that there's probably maybe be a little bit defensive too, that we wanted to control, we could control. So that was kind of the reason for doing that. So another graph kind of over time. When we started, like our base in August 2016, we had 53% of people within control of their blood pressure. We did implement a hypertension protocol, and when I say that, it was really the Million Hearts protocol that we edited and put our name on, which you can do, type in the Million Hearts package. And we couldn't embed it in our EMR. We weren't allowed to do that, so we just printed them off, hung them in every exam room right above the computer so they were visible and able to be seen by both patients and providers. Patients ever asked about it, the provider, it was right there for the provider. So just doing that, our numbers started to go up, and then they continue to go up because we were really kind of hammering any chance we get, really work on your second set of vitals, work on all these things. So they were doing a really good job with that, and we started to go up. And then we introduced a new workflow. Well, what happened when we introduced the new workflow was it was a lot of changes for people. You guys seen that assessment, right? That nursing workflow assessment. There was a lot they had to learn. So for a little bit, it did drop off, but that was just because they were learning a new process. Then after they kind of got comfortable with that, about after a month, and then we did that PDSA cycle with the manual versus auto cuffs. Our numbers basically shot up then to about 66%, and that was in January. And now we've got providers that are over 70%. I think as a whole, we're probably about 60%. So they can continue to go up. So that shows the trend line and where we kind of made interventions along.
Magnets. Pamela with Kevin had recommended we look at putting magnets or something on our door so that the nurse knew the doc wanted something rechecked. So he knew, because they don't always, the nurse is always in the room with another patient when the doc comes out from seeing the previous patient. So we started using these magnets, and they worked. They used them.
So basically, yeah, we know that communication is verbal a lot of times, but what if you don't get back and see that nurse again? What if the nurse can't see the doc? So this is a quick visual way to also communicate. They can see every door frame in their pod from their nurse's station, so you can see very easily if someone needs a blood pressure rechecked or not. So they just put it on the outside the door frame, and then when they're done, they just put it on the inside of the door frame in the room. So they're just easy to use. It's simple, and they're using them, and there's no complaint. So, or they move like those. So we talked about a little bit. So one of the things that we heard over and over from docs is, yeah, but there's white coat syndrome, and it's real, and these patients with hypertension come in, and their blood pressure is just going to be high, but their blood pressure is good at home. Okay, well that's great. We know that that is true. White coat hypertension is a true thing, but we're not asking you to get 100%. We're asking you to get 74% was our practice goal, 70 was the Million Hearts goal. So we would say, yeah, I know, you're right. White coat hypertension is real, but you don't have to get that 100 because we're only asking you to get 70 or 74. So kind of use it as a way to take some of the maybe defensiveness out, because truly white coat hypertension is true, but I think sometimes they thought we were asking them to get 100% on everything. And no, you don't have to get 100%. See, we're built in where we can have some people that aren't quite within range and still be okay. and we also had one patient that we did his blood pressure in a different room. So instead of coming into a clinic room, and he would always bring his home blood pressures in. He had his visiting nurse monitor them, and this was literally a true white coat hypertension. Every time he would come in, his blood pressure sky high, but he'd bring his stuff with him, and he'd say, "This is, everything." So we just incidentally had him in for an annual wellness visit, and we don't do those in the clinic rooms. We do them in the office because they're hands-off visits. So we just take the temptation to do extra things that you're not supposed to do out of there. And we did his blood pressure in there. His blood pressure was like, 118/75? And he even have white coat hypertension back here. He's the one who brought it up. So sometimes a little thing with patients, maybe even monitoring their environment or taking his blood pressure.
Next step, we will continue to see improvement. It's not going away forever, I have a feeling. We will continue to educate. We will continue to let our docs know their numbers, get their input, and it's constant retraining.
And they really are getting on board. I mean, I think the communication between our front desk staff, the nurses, is probably better than it. I've been there 6 years. It's better than I've ever seen it in 6 years. The docs are really getting on board. They're looking at their numbers. The nurses will come in and ask for their numbers. So they're starting to really get it, and not like we have to have this just because the government says we have to have it, so to speak. They're really looking at it and saying, we can really fix this, and we can do things better. So I think those are our big wins, and that we'll continue to do. And there's our contact information.
Great. Questions from the group first, and then I have 2 or 3 questions.
Sure.
Questions from out here?
I was really impressed by the way it seemed like several times you described how you got so far. And it's like, and you kind of said, no, you don't do that. And it just kind of, it sounded like, yeah, it depends. But it sounded like you just had a very skillful approach. It's just on, oh, no, you don't have to do that. It's just, it reminds me of a mother kind of steering her child where they need to go. But I just was impressed by the way that you took the immediate blowback from the way you described it, and just kind of reframe it and get them focused.
You have an advantage because I'm a behavioral health person. And I've worked with them in the clinic 6 years prior to this. This is kind of a new thing for me too, just back from me doing the quality. And I think we all trust each other. I think that's made a huge difference. So
Communication, though, opening up the communication lines have been huge. There used to be that barrier there, or I can't talk to the nurse about that. The front desk would, not do that. That has been broken down. We started this whole project. So that's been huge, and it's been huge having them help us break those barriers.
Questions or comments from the group? Frankly, this was more than I expected from you guys. Well, I really, truthfully, we've heard for years, right, about you always want to see charts that look like hockey sticks. And you showed us 2 hockey stick charts, right? And actually, I was thinking that one of those was what Tom said earlier. Well, we did this, and then they went to training. And then, you couldn't hardly have gotten a better picture of the way this should work. My comment is, philosophically, if we can get everybody that is a South Dakota or North Dakota person to do a project like this in the next year and a half, I will be happy. I can't speak for Tom, but I suspect he would be happy, right? Because that's really what this is about, right? And then we're just going to continue to build on that. So I'm sure you learned things, right? And I guess my question ultimately is, was that in the last 15 months?
Absolutely. Yeah. I mean, we've even had people say, and I think you even asked me this morning, well, you're a rural health clinic, why are you doing this, right? I mean, we get get paid our per diem for Medicare, whether our numbers are good or not, but we know that that's not always gonna be the case, so we might as well get on board now instead of being scrambling later. So while we have the time and kind of the protection of real health billing.
The reason I'm saying that was yesterday I had my head caved by somebody in North Dakota about that. Why would we do it? And what happened was, one of the other clinics said, just what you said, because we better get on board as soon as we can. So, by the way, Dan, I would be happy.
Okay.
I would be happy if everybody, but the most important thing that I would be happy about is to execute a project like this. Did you notice the relationships were developed? Momentum was developed. Did you notice pride was developed? Did you notice culture was developed? The nurses were asking us for our data. You know, it's like, that's kind of, and it isn't going to take like 19 of these in your clinic to have people kind of go, hey, we can do this stuff. Matter of fact, if you're teaching this, it's like the piping. You're going to make them write a little bit, and you're going to put training wheels off and be surprised how well they can do it for some other projects that really matter.
So again, I'm incredibly impressed by it, and the challenge to all of you is you can do better than if you try. That's comparative.
Well, that was cool.
So do you have any final comments?
I don't. Thanks for letting us come and speak to you guys
Thanks
today.
a lot.
I think Tom might have some final comments, and then we'll close it down, because I can't top that.
Yeah, well, I can't top it either. So as far as I'm concerned, first of all, thanks a lot for coming today. I think we have a lot of work to do. I can sit here and pound you out over the head some more, but I think everybody knows what we need to do. We can go home, take a survey of what you got, and start figuring out how you can go forward. You can talk with Tara and Kevin, and let's figure out how we get moving. And up on the chin strap, we got place to come. Yeah.
That, like I said, I can't top that.
Okay,
Thank
thanks
you
everybody.